Urine drug testing is another important application of urinary diagnostics. In fact, I did this in my clinic this past week. It's commonly used for employment screening, pain management, and detecting substance use disorders. Tests can also help guide prescribing decisions, such as before starting or increasing a controlled substance. Drug screening provides insight into recent drug exposure, though it doesn't always indicate impairment. As clinicians, we need to understand how to interpret this test specifically correctly, including the potential for a false positive or false negative, which we'll look into a little bit next. Urine drug screening involves two main methods, immunoassay and gas chromatography slash mass spectrometry. Immunoassays are most often used for initial screening because they're rapid, cheap, or affordable, and can detect a wide range of substances using antibodies. They have a high predictive value for drugs like marijuana and cocaine, but lower specificity for opioids and amphetamines. That's why a positive result should always be confirmed with a more accurate method like a GCMS before any clinical or employment decisions are made. Immunoassay testing works by using antibodies that bind to specific drug metabolites. It's very quick, it's widely available. Results often are ready within minutes. However, immunoassays can cross-react with other medications, which lead to false positives. Example, certain cold medications, antidepressants, or even ibuprofen could mimic an amphetamine or opioids on one of these tests, which is why a confirmatory test is really vital before making any assumptions about drug use. The strength of the immunoassay lies in screening, not in a definitive diagnosis. The glass chromatography mass spectrometry or GCMS method separates and identifies specific drug molecules based on their chemical structure. It would be considered your gold standard for confirmation due to its precision and accuracy. And though while it's more expensive and time consuming, it virtually eliminates the possibility of a false positive and can distinguish between a similar compound. In a forensic or a clinical case, which results with a potential legal or professional consequence, GCMS provides the definitive confirmation. It's an excellent reminder that screening and diagnostic tests are really different and serve different roles. The duration of drug detectability will depend on the substance and frequency of use. For example, cocaine and opioids are typically detectable for 1 to 3 days, whereas THC could remain positive for over 30 days in chronic users. Benzos vary from 3 to 30 days depending on whether they're short or long acting. And these windows will represent how long metabolites remain in the urine, not necessarily how long the drug has been active in the system. This distinction is really important when counseling patients or interpreting a result that's not expected. We can see false negatives in really dilute urine if the concentration is below the assay's cutoff, if the timing of the collection is too long after drug use, and some synthetic or designer drugs can also escape detection because they differ chemically from the test target's molecules. So we must always interpret results in that clinical context and not just rely on that lab report. False positives and perhaps are even more kind of common than false negatives on these tests. Many prescriptions and over-the-counter medications can cause these false positives. Bupropion, SSRIs, pseudoephedrine, proton pump inhibitors, even a poppy seed can produce a very weak, so weekly positive opioid screen. It's crucial, though, to take a thorough medication dietary history before interpreting results. And if we were concerned or things weren't matching, you'd just do a confirmatory GCMS, the gas chromatography mass spectrometry. And that's specifically important when a result could have a significant implication, like an employment or a legal problem. To ensure accuracy, urine samples must meet specific collection standards. The sample should be at least 30 milliliters with a temperature between 90 and 100 degrees Fahrenheit to confirm it's a fresh sample. The specific gravity should be within normal range and pH should fall between 4.5 to 8.5. And labs will also check for adulteration by measuring nitrite concentration or assessing for unusual appearance. These measures help verify specimen integrity and prevent any tampering, which is important for reliable drug testing. Kind of going back, if tampering was suspected, the lab looks for some telltale signs. A nitrate level above 500 milligrams per deciliter, abnormal color or odor, a pH that's too far outside the normal range could indicate adulteration. Some eventual individuals will attempt to dilute, substitute, or chemically alter urine to evade detection, which is why proper supervision, temp checks, and integrity testing are really vital. When we go through this process in our clinic, we'll oftentimes be testing individuals who we're entering into controlled substance agreements with when we're prescribing a medication that's considered a controlled substance, something I have to require my DEA license for. And so in that case, a patient will sign a paper agreeing to get their medication from only one pharmacy. There's a whole list of kind of things we agree upon, and the patient will then pee in a cup and do one of these UDS drug screens. So remember, overall, urinary testing extends far beyond just routine analysis, a back office dip. We use it to evaluate kidney function, diagnose systemic disease, assess metabolic disorders, even monitor bone and endocrine health. Tests like creatinine clearance and GFR reveal filtration capacity, protein albumin ratios detect early nephropathy, and 24-hour urine studies identify risk factors for stones. These diagnostics give us a window into the kidney and help us tailor individualized preventative and therapeutic approaches for patients. So this ends our overview of renal function and urinary diagnostic testing. We will do a little bit of a review on urine dip and urine microscopy. So that will be to come. And this is a great time to kind of reflect on some things. How do these tests kind of fit together clinically? When would you choose an eGFR versus creatinine clearance? When is a 24-hour urine collection truly necessary? Because it's totally not fun for a patient. And these are the questions you'll ask yourself clinically to order and interpret lab data in patient cases.